Good afternoon, everyone. Thank you for joining us for today's program. I'm going to turn the program over to the president, Stephanie Pitts.
Hello, and welcome to today's webinar. We're excited to have each of you join us for today's program on addressing the 3 common sources of infection transmission in healthcare. I'd first like to orient you to the webinar system so that you can fully participate in today's program. First, this webinar is accredited for 1 continuing education hour for registered nurses. If you are not a registered nurse but would still like to receive a certificate of attendance, you can indicate this when completing the webinar evaluation. The evaluation will be automatically sent to you via email within 24 hours of today's program. Please check your spam email box, as the email will come from clinicalaffairs@pdi.com. You must complete the evaluation within 30 days. It is my pleasure to introduce our speaker for today's program, Dr. Hudson Garrett. Dr. Garrett is currently employed as the Vice President, Clinical Medical Affairs for PDI, and is responsible for the Global Clinical Affairs Program, and also the Medical Science Liaison Program for all divisions within PDI. He holds a Bachelor of Science degree in Biology and Chemistry and Nursing, a dual master's in nursing and public health, a postmaster's certificate as a family nurse practitioner, a postmaster's certificate in infection prevention and infection control, and a PhD in healthcare administration and policy. He has completed the Johns Hopkins Fellows Program in Hospital Epidemiology and Infection Control and the CDC Fundamentals of Healthcare Epidemiology Program. He is board certified in family practice, critical care, vascular access, moderate sedation, legal nurse consulting, and long-term care. Dr. Garrett currently serves on the Society for Healthcare Epidemiology of America Pediatric Subcommittee, as president of the board of directors for the Vascular Access Certification Corporation, is the past education chair for the Greater Atlanta chapter of the Association for Professionals in Infection Control and Epidemiology Board of Directors, a national faculty member for the Emergency Care and Safety Institute, president of the Board of Directors for the Southeast chapter of the Infusion Nurses Society, a member of the Conference Planning Committee for the Association for Healthcare Environment, a member of the Clinical Practices Advisory Committee for the Association for Vascular Access, and a past member of the Recommended Practices Advisory Board for the Association of Perioperative Registered Nurses. In addition, he received a presidential citation from the Society of Critical Care Medicine in 2011 in recognition for his advancement of critical care nursing and infection prevention. He also serves as the chairperson for the Association for the Healthcare Environment Research Committee and is the lead faculty member for the Association for the Healthcare Environment's online certificate program in the Essentials of Infection Prevention for Environmental Service Professionals. He is also a 2-time nominee for the Ava Earps Award. He also served as a reviewer for the 2013 Best Practices in Adult Peripheral Vascular Access Resource Guide for the Association of Vascular Access and is currently an author for the 2nd revision of the Association for Vascular Access Pediatric Special Interest Organization Guidelines, which is scheduled to be released in 2014, and also an author for the AVA CDC Best Practices Resource Guide. He was also recognized as the 2013 Who's Who in Infection Prevention and Control by Infection Control Magazine. Without further ado, I'd like to turn it over to Hudson.
Thank you very much, Stephanie, and welcome everybody to the program. We're certainly thrilled that you could make it today, and we hope that this will be a very exciting and the first of 3 programs that will be taking place through the Pediatric SIG network. I do have some objectives for you and then also for myself. So the first one for the audience is to discuss the impact of contaminated surfaces, hands, and the patient's skin in the transmission of healthcare-associated infections. We're also going to talk briefly about the current research gaps that exist for pediatric infection prevention, which are pretty vast. And then finally, look at the methods to engage the patient and their family in the prevention of healthcare-associated infections. Now, I think we also have to have objectives for me. The first thing that I'd like to do is make sure that you walk away with a cost and simple, effective approach to reducing the 3 common sources of HAI transmission. We also need to figure out how we can kind of stir the pot a little bit with HAI research and create data to drive practice-specific changes to actually bring it to the pediatric bedside. Another thing that we're going to talk about is the prevention of transmission versus the prevention of the pathogen. And then lastly, we'll talk about a virtual toolkit to address the 3 common sources of transmission. So here's an outline for today's program. If at any time you do have questions, you can certainly send those in through the chat box, which will be located on the right side of your screen. Now, the first thing is I think we have to celebrate a little bit of progress that's taken place. We used to say that 1 out of every 20 hospitalized patients in the United States in acute care settings would contract a healthcare-associated infection. And that number has actually decreased, which is good. But you can see 1 in 25 is still not the best number. We need to get that to 0 out of every patient. This is associated with increased mortality and morbidity as well as cost. And what we're seeing now is that a lot of the outbreaks are occurring in outpatient settings, especially primary care offices, dialysis facilities, ambulatory surgery, and other non-hospital environments. Now, you may look at this picture and realize that the person on the left is Darcy Dolman, who many of us know. But what do these things have in common? And if you think about the Marriott Corporation, the TSA, hospitals, and professionals like Darcy and Stephanie, what do they all have in common? Well, they have a professional commitment to excellence and safety, but they have to have that done in a standardized manner. And I just recently was at a Marriott earlier this weekend, and I was so impressed with how hardwired their practices were for customer service and how they truly treated each guest as if they were a member of their own family. And if the hotel corporations can hardwire these processes, why can we not do this with hand hygiene and other infection prevention practices? Now, we also have to challenge status quo a little bit. The TSA says you can only have 1 carry-on and then 1 personal item. But we know through practices, or evidence-based practice, that many times things slip through the cracks. And in healthcare, we have things like the electronic medical record. And we have to say, what are we actually doing that's positively benefiting the patient and the providers when we put these new systems in place and sometimes these rules? Does each rule actually bring true benefit to patient safety? Now, checklists are extremely important, and we have these for insertion of central lines, but we know that the airline industry uses these every single day, hundreds and thousands of times every day. And it's important for the pilot to go outside and actually make sure that all the wings are still there, the tail, the engines look well, that the tires are not in bad shape or in near repair. These are all things that we take for granted every time we board an aircraft, but when a hospitalized patient is admitted, we don't ever think about that, and the patient is assuming that everything is done according to the right policy and procedure. Now, the World Health Organization has created an actual checklist for safer surgical care. It's a 1-page checklist that's easily designed to be used in a variety of different settings. And keep in mind that the WHO actually gears most of its materials for use in undeveloped countries, not places like the United States. However, the first week that this checklist was deployed at Harvard and the actual OR of the surgeon that invented this, he found close to 100 medical errors that were totally preventable by using this simple checklist. And the checklist is designed to go through the entire operative process. And so we do have insertion checklists, but it's very rare for us to find, for example, maintenance checklists for the prevention of eclampsia. Healthcare-associated infections have this new correlation with the Institute for Healthcare Improvement, Triple Aim. If you're not familiar with the Triple Aim, you definitely want to know this, and I'm going to provide some resource materials as a courtesy at the conclusion of today's webinar. But the Triple Aim is the whole basis for healthcare reform, and it really starts with improving the health of a population, reducing the per capita cost, and improving the experience of care that the patient has. If we do these 3 tenets of healthcare reform, we're going to decrease mortality and morbidity, we're going to take down the cost, but also improve that health of the population in which we serve. And this is really where all of the movement in healthcare reform, payment reform, and value-based purchasing is moving. Now, mortality is not just a number. And when we think of mortality, especially in the pediatric space, sometimes we hear 25% mortality from eclampsia. Or we hear if you get MRSA, the chance of mortality is 10%. But in reality, that's not just an actual statistic. It's an infant's life or a child's life or some other patient's life, and that life is affected. And if you think about 25% mortality in this particular example, that's 1 out of every 4 babies that will not actually survive that preventable event. Now, we have to learn from the past but move towards the future. And I'd like to offer a little bit of a controversial topic. The historic focus in healthcare-associated infection prevention has really been on the prevention of transmission. So we actually spend lots of money and time doing cleaning and disinfection and wearing gloves and gowns and masks and all kinds of PPE, but we're really not focusing on what we should, which is the prevention of the infection itself. And that's more of a prophylactic approach. So we're kind of at this hybrid point in healthcare right now, especially in inpatient settings, where we're doing a little bit of both, but we have to move towards that more futuristic focus and actually focus on the prevention of the physical infection. I'm going to walk through an example of that now. Now, outbreaks versus endemic problems. Well, hand hygiene is what we definitely refer to as an endemic problem because it's a culture problem. That's really the majority of healthcare-associated infection problems start from the endemic problems. We also love devices in healthcare, so we put catheters in every pretty much hole in every patient. So maybe we have a Foley catheter and we have a CBC in, or we have an ET tube in. Surgical site infections play a unique role and are closely being monitored by the CDC now. And then we have this series of adherence problems like antimicrobial stewardship and raising the rate of hand hygiene compliance and also being adherent to isolation precautions. Healthcare is continuing to change, but one of the things that scares the CDC the most is the bugs themselves, the microbes. We know that the populations continue to become more immunocompromised. With the technology that we have today, we're able to deliver infants more prematurely. And we also have transplant patients that are on immunosuppressive therapy. That combined with special environments like the ICU and burn units, a growing need for vascular access consultation services, as well as the care model shifting to more outpatient settings, creates this unique challenge with antimicrobial resistance. And I'm going to show you some recent numbers from the CDC that are quite alarming. Now, if we walk through the example of C. difficile, otherwise known as Clostridium difficile, this is the #1 threat that CDC has identified in healthcare today. It's totally preventable for the most part, but CDC is really looking at different approaches to preventing this particular pathogen and its transmission. Now, if you were to say, well, Hudson, is C. difficile something that you're concerned with as far as transmission in healthcare? My answer would really be no. I mean, that's a little surprising to people. Now, if you ask me that same exact question for things like norovirus, I would say absolutely yes, because the effective dose is so much smaller and much more easily transmittable. But C. difficile does not traditionally cause a lot of nosocomial healthcare outbreaks. We do see a lot of it coming into the facility, but it is coming in from the community in many respects. And we've always focused on the treatment or transmission-oriented approach, but never really focused on the prevention of the development of the organism. And since it's naturally occurring in most people's gut, we have to think, well, why is it actually becoming a problem? And the major causative reason for C. difficile infection is antimicrobial resistance and actually inappropriate use of antibiotics. Additionally, healthcare continues to challenge us, and it's going to continue to evolve whether we like it or not. With healthcare reform comes other legislative changes, payment incentives, value-based purchasing, and healthcare-associated infections are certainly on that list of never events. Technology also continues to evolve. We just mentioned C. difficile as an example, and there are now fecal transplants that are showing tremendous promise, but they're not widely available yet. But if you can imagine actually transplanting fecal flora from another well patient, is typically a family member, and wiping out C. difficile without the need for these aggressive antibiotics with no recurrence rate, I think most of us would sign our patients up for that immediately. It's a more substantial way to do this, and it also sustains the flora and prevents that exposure to unnecessary antibiotics. Transparency is another thing that we're seeing a huge demand for. The public wants to know what's going on in their pediatric institutions and their acute care hospitals in general. They want to know that the staff are taking the appropriate precautions according to evidence-based practices. If they don't see that through websites like hospitalcompare.gov, they're not going to actually choose those particular hospitals. So there's a lot more consumerism, especially as it relates to HAIs. Now, pathogens are continuing to evolve. This is not an all-extensive list, but the ones that quite frankly concern me the most for today's topic. Now, if you're not familiar with CRE, these are your carbapenem-resistant organisms. NPM1s are your New Delhi. These particular sets of organisms concern me a lot because they have that genetic capacity to alter themselves and become pan-resistant to antibiotics, just like the ESBLs. ESBL stands for extended spectrum beta-lactamase, and we're seeing a lot of these more resistant pathogens becoming resilient in the patients, in the environment, on the hands, environmental surfaces, and also in bloodstream infections. Yeast such as Candida albicans continue to haunt us with bloodstream infections, and of course there's our dear friend RSV, which is a pathogen that definitely shuts down NICUs quite frequently, as well as other pediatric institution floors. The CDC just released some pretty alarming data as it relates to deaths and illnesses related to antibiotic resistance. Now, this is just what they know of, and this only includes bacteria and fungal organisms. But as you can see there, we're talking about over 2 million illnesses that actually take place on an annual basis, with an estimated number of 23,000 deaths. That's a tremendous amount of preventable infections and deaths that take place from inappropriate use of antibiotics. There are ways, however, to fight back against antibiotic resistance, and they're pretty simple. The first is to actually prevent the infection in the first place. If we can do that prophylactically, then we get away from the prevention of the transmission, and I'll explain more about what that means in a minute. But we can also focus on preventing the spread of the disease in patients that are actively infected. The second rule of thumb is to track the infection. This can be done electronically or manually. It really doesn't matter, but it needs to be done in a way where there's an alert that's sent to the care provider team. You need to work in collaboration with your medical laboratory so that you get real-time alerts on these sensitive isolates. The third piece is actually improving antibiotic prescribing and actually having a full stewardship program that's multidisciplinary in nature, includes your clinical pharmacist, so that you develop a formulary and rotate your antibiotics to reduce the possible incidence of antimicrobial resistance. And last but not least is the FDA is leading a new push to develop and expedite new antimicrobial agents through the approval process. Believe it or not, the average time it takes to actually bring a new drug, prescription drug, to market is anywhere from 5 to 10 years. And this is certainly not acceptable given the threats that we're seeing today. The transmission of infection can be broken down into 3 basic categories. So let's walk through those now. The first and foremost is the contaminated hands, not just of the healthcare provider, but more importantly, the patients as well as the visitors and any family members. The second most common form of contamination is contaminated environmental surfaces. So this is everything from the bedside table to the Dynamap to the glucometer, your stethoscope, pulse oximeter, you name it. And I would really focus our efforts around high-touch surfaces, which are those that are used between multiple patients, such as blood pressure cuffs. And last but not least is the contaminated skin of the patient themselves. We know that many bloodstream infections, for example, do come directly from the patient's own flora. I think with skin hygiene, we have a tremendous opportunity for improvement here. We've focused our efforts around healthcare providers only and really not engaged the patient and their family. When you look at HCAP scores, which hospitals are measured on, this is a good way to engage your patient and get a higher HCAP score by really involving them in their care. And ask them, if anyone comes into your room and you see they have a hospital ID on, make sure they sanitize your hands or their hands in front of you. Now, hand hygiene is something that we know works, yet we still have really poor compliance with it. The average hand hygiene compliance rate nationally is only 40%. That means that 60% of the time as healthcare providers, we do not properly sanitize our hands. And this may be soap and water, which is obviously the gold standard, or with the use of alcohol-based hand rubs, which is certainly an alternative when your hands are not visibly soiled. But as you can see here, there's some frequently missed areas of the hands. You'll notice around the beds of the cuticles. This is why we do not allow fake or artificial nails or nail polish in healthcare settings, because we know that the bacteria can certainly harbor themselves there. Now, the patients are also important. How can we engage them? Well, hand hygiene is a good way to do that. We should be offering the patients and their families hand hygiene every single opportunity we have the chance to do so. At a bare minimum, before eating, after using the restroom, of course, when we're doing clinical procedures, those are all times when we can certainly offer that. And as healthcare providers, it's okay for a patient to ask us, hey, Stephanie, have you sanitized your hands? We should not be offended by a patient asking that question. The environment has a unique role in the transmission of healthcare-associated infections. Now, you may look at this particular picture and say, okay, what's an ICU room? What are those green X's? Well, the green X's represent positive VRE culture sites. What's challenging, though, about this picture is, guess what? It's a cleaned room. So there's actually a patient ready to go in this room, waiting in the hall to be wheeled in and admitted to the hospital. So if this is a clean room, we can only imagine what the same picture would look like if it was a soiled or dirty room. And pretty much all of those high-touch surfaces, from the actual blood pressure cuff, the ventilator, the patient's chart, even the sink itself is very contaminated with VRE. Now, pediatric facilities in many cases have toys, and toys are great for the kids but bad for infection prevention. Ideally, we'd like to assign toys to each child where they have their own and they can play with those, and they can be readily tossed as soon as the patient is discharged or goes home. But that's not really a reality that we face, and so toys, especially those that are plush, are very, very dangerous transmission agents, if you will, for healthcare-associated infections. The recommended practice for hard, non-porous toys would be to sanitize those between uses and actually disinfect if possible. You can do this by using your hospital-approved disinfectant, following the contact time, and then actually, once that is air-dried, you can rinse it with regular tap water and allow it to air-dry. This will mitigate some of the transmission risk that's associated with toys. Non-critical items are those that are defined as items that do not come in contact with mucous membranes or sterile body cavities. So you can see a few examples there, and they're primary things that we use in healthcare: the pulse oximeter, the glucometer, the stethoscope, blood pressure cuff, wheelchair, stretchers, those types of things. But these are items that we do know can serve as reservoirs for bacterial growth and viral growth. Some of the organisms we're studying right now have been found in the environment for up to 8 months after they inoculated on the surface. And so this is particularly troublesome in healthcare environment. There was a recent study that came out a few years ago that said even after discharge, let's say that the patient in room 212 had C. difficile or had MRSA, there could be up to a 50% rate of transmission to the next patient that entered that room despite terminal cleaning and disinfection. And so it tells us that we've got to do a better job of environmental monitoring. And really, as nurses, a lot of times we say, well, we don't have time to clean the room, and that's really environmental services responsibility. And we found that environmental services will not touch anything that's really attached to the patient, and rightfully so, because they don't want in any way damage the equipment or do anything that could harm the patient. So we need to establish with our environmental services colleagues what those rules of engagement are and who's going to clean and disinfect what. This is a little bit of a cheat sheet that I'll provide you as a follow-up to today's program. We'll talk a little bit at the end about some resources that we're going to provide electronically for you, but it shows how often should you disinfect something that's part of your patient care equipment, if it's after every patient use, on a daily basis, or a weekly basis. An example of something that would be like weekly would be a crash cart. If you're not using it often and it's not being exposed to the patients or the environment, then it really is not something that you need to go waste effort and clean and disinfect on a daily basis. An IV pole, however, if you're taking it from one patient to another, you certainly need to make sure that it's properly cleaned and disinfected. Pediatric CLABSI is one of the things that concerns me a lot, because we know that there's a huge risk, especially with CBCs being placed. In many cases, we don't find them until it's really the patient's going downhill and septic. But we also love antibiotics in healthcare, especially if you're hospitalized. And pretty much, they say about 50% of hospitalized patients do receive an antibiotic according to the CDC's latest study. Now, from a mortality and a morbidity standpoint, CLABSI certainly is up there on the top of the list, and it also adds increased length of stay, which translates to cost. And if you look at healthcare reform and value-based purchasing, we know that we're providing low quality of care, especially around things that are never events. We're really going to see a decrease in our reimbursement, and this is certainly going to hurt us financially. And we also got to consider who are those people that are most immunocompromised, definitely infants, but also oncology patients, HEMOC, whoever it may be. These are patients that we have to be very, very considerate of because of their vulnerability. Now let's talk a little bit about the physiology of the skin. And I think a lot of people have this misconception about skin antisepsis, and they do it under what they think are sterile conditions. And if you think about the skin in general, you have two basic layers, the epidermis and the dermis. The transient flora, which are found within the epidermis, are those organisms in the flora that you can physically remove through good skin antisepsis. You're removing these daily when you just take a bath alone. But skin antisepsis is designed to penetrate those top 5 layers of the actual epidermis. The dermis does, however, carry resident flora. Resident flora are those pathogens that you will not easily remove, and they're buried deep down within the pores of the skin. And so during the skin antisepsis process, our goal is not to actually sterilize the skin, but rather to reduce the amount of organisms present on the skin to a safer level. Now, if we look at this particular graphic, there's a lot of different ways that we can contaminate the patient as well as the equipment. And that's one of the reasons that skin antisepsis is particularly important. We know that anytime we break the skin, whether it be through some type of scalpel, nick, or puncture, we're actually breaking the most common barrier and the most important barrier in infection transmission, which is intact skin. Skin being the largest organ in the body, it certainly plays a tremendous role in infection transmission. So the more we can actually remove from the skin prior to insertion as well as during maintenance, the better off the chance of the patient not developing eclampsia will be. Another thing to look at is actual contamination of the device. I myself, when I had surgery back in December, was very appalled when I saw a nurse in the pre-op waiting room try to start my IV, and she missed twice and tried to use the same IV catheter multiple times that she placed down in the bed. And this is something, of course, that is not good practice, but if we imagine the patients that don't know any better or are afraid to speak up and challenge their healthcare worker, this type of contamination is taking place daily. The third to look at is contamination of the catheter hub itself. So the healthcare worker certainly does touch this, and they may not be wearing gloves, or even if they are, they may have not practiced hand hygiene. And then there's also skin contamination that can take place. And we're seeing a lot of technologies developed around this that are trying to solve that, but we really need to focus on basic best practice and ensuring that we're scrubbing those devices during every single access point according to our facility protocol. Something that we did not consider a lot and unfortunately do now is contaminated infusate. And we're seeing a lot of sterile products being recalled, especially sterile solutions. We've seen this with parenteral nutrition. We've seen this with IV bags of fluid. You name it, it's out there. And we can continue to see sterile recalls. I think I've got 2 this week just alone. And then the last to look at is an infection actually kind of seeding itself and migrating from another site. So perhaps you do have a surgical site infection and we place a PICC line. Well, that SSI might actually turn into eclampsia, if you will. And this is something that we see quite frequently. Now, the debate over chlorhexidine gluconate in neonates has finally been resolved, and I think it's an evidence-based fact that the FDA listened to pediatric clinicians. And the late Dr. Janet Pettit and Dr. Liz Sharp did some tremendous research on this, looking at what are the current practices for skin antisepsis in NICUs. And they found that over 40 to 50% of NICUs were safely using chlorhexidine gluconate in that particular age environment. To give you a little bit of history, the FDA has always contraindicated the use of chlorhexidine gluconate in infants under the age of 2 months. That has since changed based off this research as well as other data that's been published internationally, and they have changed that statement to say use with care in premature infants or infants under 2 months of age. These products may cause irritation or chemical burns. And so we really defer back to the NAN standards regarding birth weight and gestational age. Evidence-based practice is probably the thing that we most struggle with. And we say we have great evidence-based practices, but in many institutions you find people referencing textbooks or Lippincott or something of that nature, and they're not truly referencing evidence-based standards or practices. Part of that is really because we don't have a lot of evidence-based practices related to vascular access. In infection prevention, most of infection prevention, quite frankly, is common sense. And so if a physician says, well, where's the evidence to wash your hands? Well, the fact that I would even be asked a question like that is pretty infuriating, as you can imagine. But we have to really focus our efforts on improving evidence-based practices. Now, if I said, Stephanie, where should we find the most evidence-based information for the prevention of pediatric eclampsia? Well, quite frankly, I could go to any of these reputable sources that are listed here. Now, of course, since we're focusing on vascular access, I would most likely go to AVA. Of course, we have our colleagues at the Infusion Nurses Society, and then colleagues at the CDC. My little brother happens to be a malpractice attorney and does a lot of work in this particular space and has always deferred and said, well, you really need to go to the largest evidence-based guideline, particularly if it's a government published one. And so he always refers to the CDC, and I think I would agree with that. But also look for things that are specific to your practice setting. If you're doing something that's more adult-centric, then you would want to go to an adult-centric guideline. If you're looking for something that is more multidisciplinary, you're going to want to look at probably the AVA regulations and guidelines. If you're looking for things specifically focused on infection prevention only, we have our colleagues at APIC. So any of these really have good evidence-based practices associated with them, but don't think that one size fits all. Now, the guidelines that are going to be published by the pediatric SIG, as Stephanie mentioned earlier, are going to be updated later this year and released at the conference. And so this is just an example of the current CBC maintenance bundle. What I really like about it, though, is it breaks it down by part of the care process. So you can, it's a little bit fuzzy, so I apologize, but it talks about care practice, assessment, catheter site care, catheter management, and administrative practices. One of the most important things that we can do as vascular access clinicians is to have a team. And having a team alone is very, very helpful in ensuring that we're going to provide standard, consistent processes where all of our patients will benefit from the expertise. And in so many institutions, it's hard to keep a team going, and a lot of times they call it soft savings. Well, it's not soft savings. You improve patient satisfaction, you improve patient outcomes, and those facilities that have teams have certainly shown that over and over and over again. But this type of bundle maintenance piece is so helpful, and it's pictorial. So I really want to commend the work that was done by that group. Now, if we look at infection prevention research in general, there's kind of this state of the science that's taking place. And we have guidelines for the variety of different infection prevention topics listed there. We have them for central line-associated bloodstream infections, urinary tract infections, SSIs, healthcare-associated pneumonias, and MDROs. But those recommendations are really changing and evolving according to the new grading scale that's being used by the CDC. Now, you'll find that in some of the new guidelines coming out, you'll see a lot of things say no recommendation or not enough evidence. And this is a little troubling and surprising to many people, and that really goes back to randomized controlled trials not existing in those spaces. Now, sometimes it's not possible to do RCTs because of patient safety reasons and implications, as well as ethics associated with clinical research. We would certainly never want to put a patient in harm's way. But the guidelines do contain a tremendous amount of recommendations. Now, I don't know about you, but I don't want to read a 300-page document that is a whole bunch of research when I could read it in 5 pages and get the most meaningful steps for me to go out and implement at the bedside. And I think the latest study looked at it takes about 17 years to implement a clinical practice from the top all the way to the bedside and hardwire it. So if you think about some of the evidence-based practices that we have out there, think about almost 20 years it takes to get every patient to benefit from that. And how can we shorten that process? How can we actually bring these evidence-based practices to every single patient in every single unit that we serve, both in inpatient and outpatient settings? The other piece, too, is prioritization of interventions. Well, out of all the CDC guidelines that exist, and this is CDC only, for the prevention of healthcare-associated infections, guess what? There's over 1,800 Category 1 recommendations that exist, 1,800. So we can have a team of 100 infection preventionists and vascular access specialists and still not have the capacity to physically implement all of these interventions. And that's something that we just have to change. So if you go back to the 3 common sources of transmission I addressed, contaminated hands, contaminated environmental surfaces, and the contaminated skin of the patient, if we can simply fix those 3 areas and get the actual compliance up to 100% with those, we're going to literally see most healthcare-associated infections vanish from the face of the earth. Now, adherence is something that we have tremendous opportunity. The CDC publishes this data about every 2 years. And you can see here that only about 40% of U.S. hospitals are in full compliance with today's evidence-based practices. With healthcare-associated hand hygiene, 40%. So 60% of the time we just don't sanitize our hands, which is not only gross, but it's just grossly unacceptable. And all of these HAIs that we're really discussing today have true, proven, preventable methods and evidence-based practices that are associated with them. Part of it is really infrastructure. We have to have a C-suite that actually supports healthcare-associated infection prevention standards. And sometimes this can be seen as a money waster, but in reality it returns itself over and over again with the return on investment. But the fact that we have guidelines and 60% of the time we don't use those, how do we justify that to our patients? How do we tell our patients in good faith that yes, we know what to do, but we simply are not doing it? Now, we can change this, and I think a lot of it comes from great clinical practitioners at the bedside, at the forefront of nursing and other fields, involved with vascular access, but starting at the unit level. We see that the Hopkins research, for example, looked at the comprehensive unit-based safety programs, and they really talked about how do you involve those staff clinicians at the front line of taking care of the patient and build that up into more of a facility best practice. So, for example, let's say that Stephanie manages one ICU and I manage another, and she has a great practice, and she's courteous enough to share that with me as a colleague and said, hey, Hudson, why don't you try this in your ICU? And then we figure out that it works in both places. So we replicated that success. Maybe we trial it at another institution affiliated with their health system or another colleague in a different location. And we find that that also works. Well, now we know that we have an actual clinical best practice, and it's up to us to go ahead and share that information. We can then publish that through the national means, which I think is a little intimidating for some people. And here are a few examples that CDC highlights as far as some of those national best practices. The other thing to look at, too, is we never should let a good outbreak go to waste. So if you ever have an outbreak in your institution, in your unit, make sure you learn as much as possible from it so that we can actually translate that into success and actually build an evidence-based practice to prevent future outbreaks. We look at some of the issues that are associated with the VA right now. While they've provided, not very good care, there's also been an outbreak of Legionella associated with those facilities. And these things are totally preventable through good standard operating procedures. But if we learn from those outbreaks and figure out how do we hardwire it so that a human cannot override what we know is best practice, then we're going to get to a point where we can have consistency and high reliability organizations, which is particularly important with healthcare quality. The CDC guidelines continue to change. One of the great things to share with you today is that the CDC has listened loud and clear, and they have actually changed the way in which they're developing guidelines. One of the best things that they've come out with is these executive summaries. So it's anywhere from a 2 to 5 page summary of a very lengthy guideline. So you can share those brief summaries with your clinical colleagues back at your institutions and say, here, let's use this as the basis of an actual in-service. Let's talk about this for C&E or grand rounds, whatever it may be. And then roll those types of best practices out through poster presentations, peer-reviewed publications, submit to a journal, for example. The need for healthcare-associated infection prevention research is really evident. Now, we do know that we have some practices that are particularly, I think, preventive. And I think those include things like CLABSI, C. difficile, MRSA, ventilator-associated pneumonias. We have good practices out there. And in many institutions, you're seeing no ventilator-associated pneumonias. You're seeing no CLABSIs for a long period of time. But then there's also those places where you have those preventable infections where we know we have good evidence, but we don't have good implementation. And remember that I said about 60% of the time in U.S. hospitals, we know what to do, but guess what? We haven't fully implemented it. And so that would fall within that blue box. And I think the last box, which I particularly find very challenging and exciting, is situations where we don't know what to do. So if you think about, you take a PALS class and there's algorithms, well, guess what? Now you have a new patient that doesn't fit on any algorithm and we don't know what to do. Well, the common thing would be to say, how do I create that evidence? How do I create that research? And so we have to, as a profession, never say, well, there's no data for that when we know it's best practice, so we hypothesize it's best practice. But rather say, there's no data currently, but I'm going to be the first to create it. And then we go out and we replicate that success and we share it at national conferences. That's one of the best things about the AVA conference is that you get to network with your peers from all across the country and the world and learn about what's working and what's not working. And so that's really the point of this webinar series, and we hope that these particular practices are helpful to you. Now, safer healthcare is everyone's responsibility, and we have to treat it as such. We have consumers that are involved in the mix. We've got actual medical professionals such as ourselves, the patients, the government entities, healthcare facilities, the payers, the largest being CMS, and then public health agencies. And I think all too often we leave that person on the left, the patient, totally out of the picture. We, in many cases, talk around them and don't talk to them. Patients are much more educated, especially their parents. They're shopping around. There's a little bit more of that consumerism movement, but they also expect us to do what's right every single time. I was speaking to a colleague, ironically, last night, and she mentioned that her grandfather was actually in the hospital, and I, of course, was very sorry to hear that, and she said, well, what was worse was the practices that they were doing at the facility, and evidently The grandfather had actually blown his nose and took the contaminated tissue and put it on the bedside table, and the nurse came in to actually start an IV, and she would not wait for him to go wash his hands. So that's issue number one, of course. And proceeded on to open the IV start kit and actually put the supplies in the patient's bed, right on top of his contaminated linens, of course. And then proceeded to actually prep the arm with alcohol and use the contaminated tissue that was located on the bedside table to actually wipe down the patient's arm and actually dry it. And as you can imagine, this particular individual was very alarmed to see this practice, but the patient didn't know any better. So thank goodness there was an advocate in the room, which we should all have if we're ever hospitalized, to really monitor the care and ask for an explanation. And when she asked the nurse for, well, why did you do that? Is that your hospital's policy? The nurse was very stunned and said, no, that's not our policy. And she said, well, what is your policy? And she said, well, we should, do this, and we should scrub the side, allow it to air dry. Went through all the right things, but when questioned about why did you not do that, is this person not as important as a member of your family, the nurse actually said, I have to leave the room now, and she sent a charge nurse in. And so that's not the type of reaction we want to see, and this is not a nursing problem. This is a healthcare problem. And we see this across all disciplines, and we have an opportunity to improve it. But we do have to serve the patients, which not only pay our bills, but are the reasons that we went into the healthcare practice in general. So hypothetically, as we kind of wrap up today's program and open up for question and answer, if you knew that you could do something simple, easy, and cost-effective that was evidence-based but took a little extra time, would you do it? And if the answer is no, think about how you would justify that in a court of law, because we would really be called up to the stand and ask that question. If we could do something, though, that would make that patient's experience better, that's a whole other question that we have to consider. And with healthcare reform comes payment incentives around HCAHPS scores and patient engagement and improvement and quality and safety. So they want to know that the patient was satisfied and that we were properly treating them and engaging them in their care. So a call to action. I think the first thing is that the power of one individual is very, very powerful. If you have one person in the unit that is an agent of change, or maybe it's one person in an agent of change universe where they are the champion for the system for CLABSI, or maybe they're the person that raises the red flag and says, we can prevent these infections, and they start a movement. That's very powerful. The second thing is the patient has to be the center of the universe. The patient and their families have to be part and engaged in their care. They have to understand what we're doing and why. But I also challenge the patient to stand up and say when they think something is not going well. And I think more and more patients are doing this. But a lot of patients don't know if we're doing the right thing. And basic things like telling the patient, if any healthcare worker comes in and they're not sanitizing their hands, you have the right and the responsibility to speak up and say, sir, I need you to please sanitize your hands. And if we just did it right outside, we shouldn't be defensive and say, well, I'm sorry, we can't, I've already done that. We have to really actually take that practice forward. The third thing is really addressing those three common sources of transmission. If we can get rid of the contamination on the hands, the environmental surfaces, and the skin, again, we're going to eliminate the majority of these deadly healthcare-associated infections. And last is aligning your practice with the IHI triple aim. And that's, again, improving the quality and patient experience, reducing the per capita costs, but improving the health of the population. As a healthcare system, if you're part of the healthcare system and you do this, it's really going to benefit you very, very heavily with your payments. The references for today's program are contained here. Any of these links are live, and you can actually click those, and it will take you directly to the websites. The CDC website in particular is very, very helpful, and all the resources there are free, so you can use those at any point. And what I'll do is I'll open it up for question and answer. Before I do that and turn it back over to Stephanie in case we have any questions, you will receive an email following today's program. On that, you'll find not only your C&E certificate, but also about 10 different digital resources that are yours to keep and use in your institution. All of the materials from today's program are derived from the best practices from CDC and other organizations. But we wanted to share with you some patient-focused materials on CLABSI prevention, for example. There's materials in there about the IHI triple aim and some other good references on disinfection and sterilization. These are yours to keep. You can certainly share these throughout your institution and use them how you see fit. With that, I will go ahead and stop, and we'll open it up for question and answer, and then we'll actually turn it back over to Stephanie. The first question that we have today is, can you please review the proper methods for disinfecting toys? And this is a great question. Whatever hospital-approved disinfectant you use should be fine. Most places will use an intermediate level disinfectant. The way that you'll know that it's an intermediate level disinfectant is it will have efficacy against microbacterium. An example of that would be tuberculosis, or you'll also see hepatitis B and HIV claims on there. That will tell you that it's intermediate, and that's the best one to use. So you would go ahead and actually disinfect the toy. It needs to be a hard, non-porous surface, and you would follow the contact time, whatever that overall contact time is. So let's say it was 2 or 3 minutes. Then you would need to allow it to just air dry. And then once that air drying process has taken place, you would actually go ahead and rinse it with tap water and then allow it to air dry, and that would take care of the disinfection of toys. And the reason that we rinse it is to remove any potential residue that might be out there. The second question is are there certain disinfectants that are better to use in units that have RSV? Another excellent question. Any of these EPA-registered disinfectants would be mostly appropriate. The recommendation from myself would typically be to use an intermediate-level disinfectant, and you could certainly do that, and that would be no problem. But you would want to look for that type of claim against either RSV or another like virus. It's really impossible to test every single virus on disinfectant. But if you see another virus in the same category, then that would certainly be acceptable. The next question we have is, how do you feel about plush toys and heated humidified isolettes in the NICU? That is another very good question, and I think you will not like my answer. That is a dangerous practice. Anything that's plush is going to be considered porous. We know that not only will bacteria attract to it, but it will also grow with the fibers that are there. And you really can't clean those plush toys. So the recommendation, if you did need to use those, would be for them to be single patient use, and disinfect them as much as you can. If you have some type of disinfectant that can be used on that, but typically you can't. These would not need to be shared between any patients. The other challenge is if you're in a humidified environment, is that you're going to create bacterial and viral growth on those. And so there's really not a good way to handle that in that type of environment. That's something that you would need to really think about heavily. I know it's certainly a patient comfort, but from an infection prevention standpoint, it would not be a safe practice. The next question is, can UV light still be used for equipment disinfection? Typically, you're not going to see UV light used for initial disinfection. There are some practices and technologies out there where UV light can be used as an adjunct to cleaning and disinfection, but it's typically not a technology that you'd rely on just by itself. The next question is would it be okay to clean a neonate skin with CHG that's less than 2 months of age and then wipe the site with a sterile saline to decrease the incidence of skin irritation? That would be okay if that's something you absolutely had to do. Typically, the practice is to leave the skin antiseptic in place, and the reason being is that if the skin antiseptic is actually in place, it continues to have some antimicrobial persistence on the skin. If you do remove it from the skin, which you cannot fully do, especially with chlorhexidine, sterile saline, sterile water will start to deactivate it a little bit, but it does not fully remove it. If you had a neonate where you had skin concerns, then I think that would certainly be a safe practice, and I know NAN addresses that as well. I would want to caution you, though, if you have infants with premature skin where they just don't have any skin integrity, it's really not going to be appropriate to use any of those antiseptics. Just because of the skin maturation factor. Okay, looks like we have a few more questions. The next question is how do we improve hand hygiene for the family members in my NICU? And the question goes on to say that we have about an 85% compliance with staff hand hygiene. One thing I would offer is that staff hand hygiene is very subjective. It's typically done by secret shoppers. So if your rate is 85% or you think it is, it probably is more like 50% if somebody from the outside were to come in and truly observe. We always have these falsely inflated numbers typically for hand hygiene, and it's a very subjective practice, as I mentioned. As it relates to patients and the visitors, it's something that we have to continue to improve. One of the best ways to do this is if you have a controlled unit or environment, you can actually lock it down and require them to practice hand hygiene before they come in. And this can be done with the assistance of a volunteer, a unit clerk or secretary, whoever it may be, but this is a good way to do that. Then when they come into the patient's room, they should also be required by a staff member to sanitize their hands again. and of course, at any point during the infant's care or the child's care where it makes sense, and then when they leave the unit. So those are some ways to improve compliance, but more importantly, to keep some of these community pathogens out of your units, which is very, very difficult. If we have a patient, the next question is, if we have a patient that's allergic to CHG or betadine, what can we use, and can you actually leave it on, or should you clean it off? And so this particular question is problematic because there are not a lot of solutions out there in the U.S. market. The true anaphylaxis rate to chlorhexidine is pretty minuscule. If it's something with betadine, we do know that there's a tremendous amount of people that do have allergic and anaphylactic reactions. When you use chlorhexidine, because it does contain alcohol, alcohol by itself makes the skin red, and that erythema is perfectly normal. Now, if that erythema does not disappear in between 2 and 4 hours, then you would need to be concerned about a sensitivity. But true reactions in anaphylaxis to chlorhexidine is very, very rare. If you did have a patient that was allergic and you used betadine, betadine is twice as irritating to the patient's skin as chlorhexidine, believe it or not. And so you can leave it on the skin if you need to, but you can certainly also clean it off with sterile saline or alcohol. If you use alcohol if it's on an infant, I would caution you about that because it does actually dry out the skin a little bit, and it could cause problems later on. The next question is, we have, we're in a NICU and we have problems with visitors using their cell phones while holding infants. We feel that cell phones are contaminated and a source of infection. This is a great question, and I'm glad you brought it up. Cell phones and pretty much anything that we have in our possession is contaminated. My own cell phone, I actually cultured it a few years ago, and I grew up C. difficile, VRE, and MRSA. Now, you know, I clean my cell phone regularly. I certainly clean it more than I did before after that experience, but pretty much all these things are contaminated. And so I think you're right on the right track as far as thinking about this potential source of contamination. Now, if you think about the process, so you've got a cell phone, they're holding it against their shoulder, and they have an infant in their arms, the risk of transmission is pretty right in front of our face. And so I would not allow that personally if that was in my institution. And I think that's something you should address with the parents and let them know that this is a safety concern that you have. And it also could be disruptive to the infant's healing process also. Okay. The next question is I'm not sure I understand this, so hopefully I do. But as far as the hypothetical question, excuse me, if we could do things differently and actually do the right thing, how would we change that practice? I think a lot of this, quite frankly, has to come from the C-suite. Our executive teams have to demand and expect that regardless of the situation or the cost, that we will do the right thing each and every time. And those of us that get on an airplane, I get on an airplane every single week, I expect that Delta Airlines will do the right thing despite the cost, and we'll always have 2 engines, and we'll always have the most, properly trained pilots and flight attendants. So why would that be any different in healthcare? And I think that we have to continue to challenge the system, continue to challenge status quo, and not accept no for an answer. If I ran a hospital and people did not get flu shots, for example, I would probably start firing people because we have this privilege of working in healthcare. It's not a right. And when we take care of these immunocompromised patients, I want to make sure that they have the best chance of survival. And quite frankly, I would not want to be the person that would give them an infection. And so I think we have to continue to challenge our peers in a professional way, but also seek that administrative level support. It looks like we have one more question. And the last question is there a way to hardwire addressing these 3 common sources of transmission that you discussed? And that's an excellent question. This really has to be done in collaboration with your nursing colleagues, your infection prevention colleagues, as well as your environmental services colleagues. And I think we can't do it alone. If you get environmental services in the room and you say, within this 3-foot circle of the bed, I will, as a nurse, clean these areas every single day, but I expect you to clean and disinfect the other areas that are in the patient's room. This is one way to have that conversation. Another thing, too, is to check into the Team STEP program. If you're not familiar with it, we're going to be addressing that, I think, on the second webinar that'll be hosted through the Pediatric SIG later this year. But that program is really designed to improve communication and collaboration and break down barriers that prevent good quality patient care from occurring. That's another thing that we have to address is how do we properly communicate those expectations. But getting all of those players on a unit-by-unit basis and also with administration involved is a good way to do that. But as nursing colleagues, we have to also take ownership and say, Yes, we did not go to nursing school to clean and disinfect equipment, but it's our responsibility to care for our patient, especially for those pieces of equipment that are actually attached to the patient. As a final follow-up, and then I'll turn it back over to our President, Stephanie, is you will receive an email in a few minutes. We'd ask that you take the time to complete the program evaluation. That will allow you to download not only the electronic resources, but also your CME certificate. I did get several questions about copies of the presentation. We're happy to provide that, and it is also included on the link as a PDF file, and you're welcome to share that information. If you do have any additional questions, feel free to reach out to me at any point. You can see both my work and my personal email address there, but more importantly, we appreciate the time that you took out of today's schedule to join us. So Stephanie, I'll turn it back over to you to close us out.
Thank you, Dr. Garrett. I'd really like to thank you for sharing your expertise with us, as well as your support for the Pediatric Special Interest Group. Ultimately, I'd really like to thank you for challenging each and every one of us to raise the bar and to challenge the norm to improve outcomes for really our littlest patients. For our webinar attendees, thank you for your participation in today's webinar that is accredited for one continuing education hour for registered nurses. If you're not a registered nurse but would still like to receive a certificate of attendance, you can indicate this when completing the webinar evaluation. The evaluation will be automatically sent to you via email within 24 hours of today's program. Please check your spam email box. You must complete the evaluation within 30 days. In addition, the slides from today's program will be included in the email with the program evaluation. This concludes today's continuing education program, and we look forward to your participation in the 2 upcoming webinars remaining in the series. Thank you much.